Welcome to today's broadcast of North Idaho College Public Forum. The crew is comprised of NIC television students, and your moderator is North Idaho College political scientist Tony Stewart.
Today is another milestone in our history of the North Idaho College TV Public Forum. With this program today, we bring to you the beginning of the 17th year of this production. We are so happy to have been on the air for so very long. It is very appropriate to start this 17th year with a very special guest and someone who will be most informative, and I'm also pleased to announce that I'm able to start the program not only with an outstanding expert, but also a friend for the past 18 years. Welcome to the program, Dr. Michael Frampton. Dr. Frampton grew up in Coeur d'Alene and graduated from the Coeur d'Alene High School system in 1974. He received his baccalaureate degree from the University of Portland in 1978 in the field of biology. He then attended and graduated from the University of Washington Medical School, graduating from that institution with an MD degree in 1983. He had 1 year residency in medicine and 3 years residency in psychiatry at the University of Rochester in New York. Then he had 1 year in clinical instruction, and he's taking a very brief time off to be here before he goes to Cambridge, England for a postgraduate study of a year in the history of medicine. Mike, it's a pleasure to see you again and to have you on our program.
Thank you, Tony. Nice to be here.
And as always, I'm very happy to welcome our regular panelists to question our guest. First of all, to my immediate left is Janelle Burke, who is an attorney practicing in Coeur d'Alene, actually is a law clerk for one of the judges in our district court system. And next to her is Steve Schenck, who is the Dean of College Relations and Development at North Idaho College. And I will ask Janelle Burke to commence the questioning.
Well, Dr. Frampton, first of all, to set the stage for this program, could you explain to us the difference between psychology and psychiatry? And then a second part to that question, would you elaborate a bit then on your training, which makes you a psychiatrist?
Well, the basic difference between a psychologist and a psychiatrist is that a psychiatrist has an MD degree, and psychiatry is merely a subspecialty of medicine. And whereas a psychologist is a PhD student, he graduates with a PhD as opposed to an MD. And I guess in practical terms, the main difference that makes is that a psychiatrist is able to prescribe medications and to admit patients to the hospital.
And in what ways then did your special training help you to become a psychiatrist as opposed to a regular MD? What areas have you what specialty areas have you studied?
Well, just psychiatry. There are various residency programs in the country, and psychiatry is just one of those. It's a 4-year program, and a year of that, the first year, is spent in general medicine so that we get a good grasp of the biological aspects of illness before we move on to the psychological aspects. Because we need to know, I think as psychiatrists, we need to be able to sort out what is a physical as opposed to a mental illness. And people are a complex mixture of both, and I think that's a very important thing to do. And I think that's the advantage that getting the MD degree has, is that you are able to do that better.
And I take it then that you study both the theory of disease and you also do some practical reaction to the disease. Is that correct?
Oh, yes. Your clinical or hands-on experience begins your 3rd year in medical school. So you get 2 years in medical school, and then you do an internship, at which point you begin taking on more responsibility. You've got your MD degree, and you're supervised largely by a senior resident or the patient's attending physician. And you write orders, and you do all the management aspects, and you carry a caseload of a very significant caseload. It's like an apprenticeship, really, and you learn as you work.
And from that point then, what made you decide that you wanted to do postgraduate study? Are there specialties within the field of psychiatry?
Yes. In fact, a real burgeoning area in psychiatry is geriatric psychiatry, and the other is child and adolescent psychiatry, both which are just wide open for whoever wants to go.
So then what made you decide to do postgraduate study?
Well, I'm taking a little bit different direction. I'm studying the history of medicine this next year, and that's not really a subspecialty of psychiatry. It's just a totally different field, really, and I may end up subspecializing when I get done with that. But for the time being, I'm just a general psychiatrist and really haven't developed any specific interest in a subspecialty of psychiatry.
Steve Sheen.
Dr. Frampton, was your initial medical training the same as any other doctors would be?
Yes. It's very uniform, very
When you
standard.
entered medical school, was it your intention to become a psychiatrist, or
No.
did that interest develop along the way?
That developed along the way. You, in your third year, you get 2 years of books, and then you get 2 years of clinical, where you're actually, as you say, confronted with the patient. You need to react or act, and it became apparent to me that I like psychiatry the best. There's basically 5 different basic rotations that you do your third year, and they're 6 to 12 weeks each. You get surgery and medicine, pediatrics, and psychiatry, and OBGYN. Those are the big 5, and at that point you need to decide, what will I do the rest of my life, and then you apply to the appropriate residency training. And I think almost without exception, people specialize in one aspect or another. There's just too much knowledge to do an internship and then begin practice right away, although some people do that.
I want to get back to your postgraduate studies eventually, but you made a comment a minute ago about a fine line between physical and mental health. Was there something about that line that occurred to you in that rotation period that steered you towards psychiatry?
Well, that's what I find the most fascinating, is the study of that line and where they meet, how they interact, the mental and the physical, the impact of the one on the other. I find that just, in philosophy, it's called the mind-body problem, and it really does have, in psychiatry, it has a very practical, day-to-day reality that I really enjoy.
Are physical problems often misdiagnosed as mental ones and vice versa?
Yes, without a doubt.
How frequently, how common an occurrence would you say that is?
Well, it's common on both sides. We do a consultation rotation where we consult medically ill patients on the medical side of the hospital, and it's amazing what they will miss on the mental side. But what's maybe more interesting is what they'll actually miss on the physical side. Often they'll come in and they'll consult us, say, we think this person is hysterical or psychotic, and we find out that there's a very plausible physical etiology for their behavioral change or their mental symptoms, and it seems like more than half the time you ask them to rule out various organic etiologies for their symptoms before we're ready to put our diagnosis on the line that this is strictly a functional as opposed to an organic or physical illness.
I think that most of us probably get our view of psychiatry from television, and we think in terms of crazed killers more than anything else. But are you frequently called in to consult on problems where there is a mental aspect to an illness, but we're not talking about someone who is certifiably insane, but there's a mental problem that's contributing to physical unhealth?
Mm-hmm. Well, my experience is mostly you're consulted by an internist or a surgeon when there's a behavioral problem. And I'm speaking about an inpatient unit because that's where most of my experience has been. When somebody's causing some sort of trouble, it's that vague. This person is angry and yelling and tearing apart his room, and that's about as much information as one gets most of the time. And then you have to go in there and figure out what's going on, and you have to take a multi-layered approach. I think that's what I learned in psychiatry. There is no monolithic explanation for behavior or symptoms, and we have to take a individual family, psychological, social, economic approach to each and every case, and I think that's what I was impressed with at where I was trained, is the multiple levels that, you know, who knows what causes what, but you have to attack each and every one.
I think this is an excellent time to interject. Mike certainly has a very fine way of explaining to people what we're talking about in the categories or axes of the problem of mental illness and the whole issue of mental health. And so often on this program we're trying to, with our general audience, to assist them in understanding that they may have someone in their family that has certain problems, but there are other problems too. Would you take a moment to categorize this for us and explain the different areas?
Well, what people in the mental health professions as a whole use as their basic Bible, if you will, for diagnosis is the DSM-3. It's 3 just refers to, it's the third revision of the Diagnostic and Statistical Manual, and it's a purely descriptive, doesn't say anything about etiology or anything. It's at a purely descriptive level, and it's broken down into 3 major axes. Axis 1, 2, and 3. These are the different levels that I was talking about. Usually the axis 1 is a major sort of psychotic illness, schizophrenia, major depression, manic depressive illness, these sorts of major well-known illnesses. And axis 2 are illnesses that are not so amenable to pharmacological intervention, personality disorders, long-standing behavioral problems. And axis 3 is more the strictly organic diagnosis, if there is one, that may be a contributing factor to axis 1 or axis 2. There's 2 other axes that take into account the level of function of the person over the last year and the stressors that are involved. So it takes into account the organic, the environmental, the premorbid functioning, all in a big heap.
I want to pursue another area before going to the panel, because I had the advantage of having lunch with our guest, and so he said a number of things that was very, very important and fascinating to me. In our society, there's been a public policy decision that more and more patients within mental institutions under institutionalization are being returned to the community, to the home. And I wish you'd take a few minutes to share with our viewers, in particular those that might have this experience, what that process is, that in particular categories of mental illness, how there has to be a coordination between, or there's some new pioneering, I guess, that's taking place in bringing a lot of people in on this treatment, not only the professional like yourself, but the role of the family and others in the community. My question is a quite vague one, but would you tell us what we're learning that may increase the chances of this person returning to a better mental health, or not to be institutionalized again?
Well, that's right. Since the 60s, there's been a gradual deinstitutionalization of the chronically mentally ill, most of them, the axis 1, schizophrenia, these sorts of things. And but what do you do? You know, they're still chronically ill, and you know, there aren't enough psychiatrists to go around, and you can't you know, lock them up anymore. So what do you do? Well, what you're seeing, I think, you're seeing a huge growth of other people getting involved, you know, nurses, social workers, psychologists, and last but not least is the family, which has been maybe an underestimated component to the treatment. In fact, I think psychoanalytic theories have tended to blame the family for the schizophrenic, the so-called schizophrenogenic mother, for example, who drives her kid crazy. They're really getting away from that, and they're studying, especially in schizophrenia, they're making some very specific studies and recommendations flowing out of those about really how to help the family deal with this person who has such aberrant and bizarre and way out behavior and hallucinations, and what they're studying that intensively now, and they're finding that, in fact, the appropriate kinds of responses to the ill person really has an impact on their relapse, and it's incredible. Probably it's equal to the medication as far as preventing relapse within the next 5 years, and the two together are probably the best.
Now, can you give us a couple examples? I know we have viewers that are curious of what families are being taught to do to help. Some of this is just very subtle, but how can they adjust their behavior to assist, or what are some of the things they're doing that are adding to the problem?
Well, there's a whole array of studies that are really focusing on the family's response to the ill person. You can imagine that it could be scary. There's strong feelings are evoked in the family: fear, anger, depression, and they react to that. And what they're really teaching, they call it expressed emotion. They're trying to decrease the reactivity of the family member towards the ill person. And what they're finding is if they can deal with their own feelings towards this person and react with more empathy and understanding and less raw emotion, that the person tends not to relapse. But they call it expressed emotion, and they quantify it, and they do these detailed tapings, and they correlate which kinds of the tone of the interaction, the words used, and I mean it's very detailed, and they really have very specific recommendations on how to interact, and I think it's very, very helpful.
Janelle Burke.
In many diseases, we can chart the progress of the disease, and we're looking for cures, for example, in cancer and so forth. What about with mental illnesses? What is the progress? Is any being made? Are there studies that indicate that we're better off today than we were at diagnosis, at treatment, it's a cure? I think in many cases we believe that once mentally ill, it lasts forever. So what is your response to that kind of a question?
Well, I think we're really just beginning. I think in many ways psychiatry is at a very sort of primitive stage of science, if you will. It's the DSM-3, I think, reflects that. It's a purely descriptive level of explanation. They don't get into causes or etiologies or any of these sorts of things. It, I think, is maybe just beginning the progress. What is it that is going on here? It's probably at the phase that physical aspects of medicine were at 100 years ago. After all, it was only in 1954 that they introduced chlorpromazine, which is the very first antipsychotic, and it was with that they could stop doing all this electroconvulsive therapy and release the people from their restraints, and that was 35 years ago. And I think the research, I think the future probably of psychiatry is very good in that. I think they're just really beginning to involve the neurosciences in a very intensive manner, and right now there's probably a lot of what might be perceived as chaos in the field, a lot of different competing theories on mental illness, a lot of competing sects on mental illness. We think it's a virus, we think it's an immune problem. I've been watching these daytime shows on my vacation, and it's very enlightening in a way to see what is the sort of common perception of mental illness and its causes. And I mean it has not been sorted out, and I don't think a real sort of monolithic movement has emerged yet.
Are we better at diagnosing now than psychiatrists were or doctors were in the past as to exactly what was happening and why a person might need to be institutionalized or treated for a period of time? Yeah,
I think probably the greatest strides have been in just what is it we're talking about, and are we talking about the same thing? That's what they call inter-rater reliability. If Dr. X sees a patient and Dr. Y sees a patient, what's the amount of agreement? In the past, I think it was up for grabs. There was this DSM-3, I think, has introduced an organizing principle into psychiatry on a descriptive level. Are we talking about the same thing, and what is it we're seeing?
For example, with Alzheimer's, would there be a more advanced diagnosis now than there was a few years in the past when people didn't really know what was causing that? And now, as I understand, it is being considered something that was caused by the body as opposed to just generally senility.
That's right. You are seeing probably a lot of so-called mental illnesses will eventually, like Alzheimer's, become specifically a brain disease, and that's exactly what they're finding. They're correlating symptoms and course with post-mortem studies of the brain and the brain function and all these sorts of things. And I think what we'll be seeing is the neurologists will be stealing a lot of our patients away. Although, interestingly, even though I believe, and it's proven that Alzheimer's is a brain disease, it's interesting that psychiatrists still remain very involved in the treatment of Alzheimer's because it presents such a social and such a social and family problem. Their behavioral, their loss of memory, and loss of cognitive function really has a huge impact on society and the family, and that's why psychiatrists remain involved, even though, strictly speaking, it's a brain disease. It's not a mental illness at all.
Steve Sheen.
Doctor, how common is mental illness in this country today?
Well,
are there reliable figures about it?
Yeah, there are. It depends on what you mean by mental illness, and well, why don't I stick with schizophrenia, which is a very well-known entity, at least,
and a serious form of
and
it.
a serious, very serious. The cross-cultural studies have come up with figures between 0.7 and 1% incidence of schizophrenia. That means that 1%, 1 out of 100 people that are born will end up getting schizophrenia, which is an incredible amount. I mean, 250, that's in the whole world, and they've done, it's not just a cultural phenomenon, they've studied it in China and Sweden and Switzerland, and they really find that it seems to be a very real entity that is incredibly prevalent. It's surprising, and that's one of the major illnesses, and depression is more common. It happens to be perhaps more treatable, but you go down the line and they're even more common. I don't know what the average percent of all mental illness. Plus, you have to distinguish reactionary problems that go away once the environment is manipulated. But maybe 15. I've heard depression is 15 to 20%.
Is that? Are there studies, figures available to you that would indicate whether or not societal factors or environmental factors or occupational factors contribute to that? And I guess what I'm getting at with that question is, how do we compare with other countries that could be expected to keep good records, to know roughly what the population of their own is with mental problems?
Well, they're just really beginning to do cross-cultural studies, and I don't think the United States, from what I've been exposed to, is any more, we have more mental illness than anybody else. I think there are differences in diagnoses. I think there are different perceptions of mental illness, but somehow these people get labeled, and whatever the label is, whether it's labeled as mental illness or whatever, a behavioral problem, I think it exists in all societies.
You mentioned geriatric and child psychiatry as areas of the profession that are growing rapidly. Are there other significant trends in the
psychiatry?
Your field? Yes.
Well, I think what we're seeing in general is a swing in psychiatry toward a biological determination of mental illness. I don't really know what all the factors are in that, except maybe it's sort of a reaction to Freudianism, which is ultra psychological and environmental, and didn't really take into account the brain. And it's also might have some political reasons. There are a lot of non-MDs getting into the mental health game, if you will, social workers, RNs, psychologists, competing really for treatment of patients, and maybe the MDs are sort of staking out their territory. Well, we'll take care of the the physical stuff, and we're going to put our thrust here, while the social workers are more interested in family and social manipulations, and the psychologists are interested in the individual interaction with them in the office. So I think psychiatry in general is definitely moving towards the neurosciences.
Mike, I wanted to pursue another area. I was very impressed when you made this comment at lunch today. and I'm not taking away from the importance of professionals such as psychiatrists and psychologists, and obviously we can see what they've done to the field. But you indicated, and I would like for you to express your views on this, that individuals who don't have certain types of mental illness or in certain behavior they may never move toward a mental health problem, is if they have in their life a support system, or they have a friend, or they have family and so forth. Mm-hmm. And the comment that so struck me as important of your objectivity is to say everybody doesn't need a psychiatrist. Mm-hmm. If they have certain people in their life. Would you elaborate upon that?
Well, the DSM-3 that I was describing to you is really is not comprehensive by any means. It's staked out a certain mm-hmm. amount of territory, and it's sticking to that. Outside of the diagnostic manual are problems of living. There are there's unhappiness, loneliness, lack of direction, all these sorts of things, and perhaps in our fragmented society, lack of extended family, and there's the increasing complexity of society. All these factors, I think, make it difficult for the individual to navigate a course through and live up to his or her potential. And I think you really need someone that believes in you, has faith in you, that you have a valuable contribution to make, whatever that might be. And it doesn't have to be a psychiatrist or a psychologist to do that. A mentor serves that function. Friends, teachers, anybody that somehow helps you believe in yourself and gives your life meaning and direction. That can serve just fine.
Are you suggesting that that's part of a preventive process too, if that's in place in a society?
Sure. Yeah. I think everybody needs it, and where you get it, it doesn't really matter. It really doesn't matter. But I think we're social animals, and I think we need that contact, that understanding, that nurturance, that fostering of your potential. Otherwise, it'll just lay there, and it won't. You'll be unhappy. You'll have a sense of some vague, free-floating sense of lack of fulfillment, unhappiness, and I think it really takes someone to draw that out of you.
With that, I have to bring our program to conclusion. I know the panel joins me in saying you wish that we all had more time to deal with our guests. It's been most informative, and it's been personally very rewarding to me to have you back and to see you after all these years, and I know our viewers have enjoyed this subject very much, and you've been most articulate. Thank you, Mike, for being with us.
Well, thank you, Tony. Enjoyed it.
Ladies and gentlemen, our guest has been Dr. Michael Frampton, who is MD, and also his field is psychiatry, and we've been discussing that important issue. It was a very great way to start the 17th year of the North Idaho College Public Forum. We look forward to the 17th year, and we'll bring you guests on many subjects. We invite you to write to us during this year, and we answer all mail and all inquiries, and we look for a successful year. Until next week, please have a good week. I am Tony Stewart.
North Idaho College Public Forum can be seen at the same time each week over this station. This production was videotaped earlier by an NIC student crew for viewing at this more appropriate time.